The average patient in Cardiff's main hospital is female, 85 years old, and has 5 comorbidities. 5. So the good news, we're all living longer. The bad news is we are not living healthier by any stretch of the imagination. Globally, we spend $10 trillion every year on healthcare. $10 trillion. And the majority of that is spent in the Western world, and most of that is spent managing people in the last 7 to 10 days of their life. Imagine a future where we spend that money on keeping people healthy and out of hospital, so that you're not 85 with 5 comorbidities in a hospital. Because Cardiff is not, I stress, not unusual in that sense. And I think the challenge for us and the opportunity is that the demographics all point the same way. Increasing demand for healthcare, and not just increasing demand because we're all getting older, but increasing demand because we expect more of our healthcare system. We actually are not prepared to put up with being sat in a corner and spoon-fed. We do want to live those healthier lives. So I'm slightly concerned that Alan has rather built me up hugely, because in 15 minutes I'm not going to be able to do much more than give you a very brief overview of life science, and I'm just going to try and whet your appetite. I'm going to try and show you some examples from NPL of what we're doing with technology in life sciences and healthcare. It by no means covers the full breadth of everything that is going on, and I can only touch on a couple of different technologies. But if you start to think about the need to image, to sense, to manage data, they are all things that we see in our other aspects of technology throughout our lives. I do promise I won't show any gory pictures. I took them out. I was a bit worried that you wouldn't like them. Notwithstanding anything around being in a general election campaign and all bets being off about the industrial strategy, I think it is fair to say that this problem of healthcare and how we deliver good quality healthcare going forward has been well recognised by government, by various reports that have gone to them. And I think particularly, Hussein, you were spot on earlier when you talked about the opportunities in the medical technologies market. The global medtech market is worth about $426 billion, 115 billion euros, so that's the European market, 10 billion in the UK. And the interesting thing is that in the UK, we import about 50% of that medical technology. We import. And that's despite us having a strong medtech sector, which is fairly well distributed actually throughout the UK. So I think that there is a massive opportunity for more people to get involved in not just the end point of the medical technology, but the supply chain in medical technology and how we can do that better. Because one thing that is absolutely certain is we are not going to manage the potential healthcare crisis by doing more of the same. We simply have to recognise the role that technology can play for us. So, quick show of hands. How many people in the room have heard of NPL? Oh, brilliant. That's great. So you know who we are. I haven't got to explain it. So you might ask, why is the UK's National Measurement Institute interested in healthcare? What's our role to play in that? It's because we do provide that confidence in measurement, because we're impartial, we're independent. We are there to support industry in terms of making sure that you've got the measurement techniques that you need to support innovation coming through. We're there to make sure that it's internationally recognized so that you can trade internationally on the basis of the measurements you make, and that those measurements can be reproducible. And without all of those things in place, none of us can operate, and we certainly can't bring new technologies to market. We do work across all the sectors that you play in. We focus on advanced manufacturing, on digital. So we have a massive role that we're playing at the moment in 5G, timing infrastructure in the UK, and in energy and the environment, in clean energy particularly. The huge challenge of, yes, we've got plenty of solar energy. We have no viable way at the moment of storing that and transmitting that effectively so that we can really make use of it. But particularly in the life sciences sector, there are three things that we particularly do. The first is that we provide that traceable assurance, and I'll give you a couple of examples of why that's really important. The second is that we help people and we ourselves innovate technology to bring new approaches to medical care to market and to the clinic. And what's really emerging, as in every other sector, is the huge, huge importance of data. And we certainly can't lose sight of that. Data that can support earlier diagnosis so that we can prevent illness as opposed to manage or treat illness at the end. So, first example. If you are unlucky enough to need radiotherapy, I certainly recommend that you come and have it in the UK. And the reason is because over the last 10 years in the UK, we've established a traceable system of calibration and audit across UK hospitals. What that means is that linear accelerators across the UK are calibrated to the primary standard that we hold at NPL. We send out phantoms. What do I mean by a phantom? It's a bit of plastic that has been developed to mimic a human body, and we set instructions for the radiotherapists and the medical physics to put that into their linear accelerator. We put some sensors on it, they send the data back to us, and we check that they have calibrated their linear accelerator and they are delivering the right dose every time to every patient. Because it's all too easy to give the wrong dose, and either it's not effective, or unfortunately, your treatment is your kill. So that's really important, and we work very closely, particularly in the UK, with Elekta, who are a major supplier of linear accelerators. We've got 2 on site. Elekta work very closely with us in terms of keeping us up to speed with how they want to develop those linear accelerators, take advantage of new ways of delivering radiotherapy, target that radiotherapy more effectively. And so we're continuously working with them on how we can improve outcomes of radiotherapy treatment. And we can only do that because we can measure that precisely and provide that traceability back through. Second area of traceability. SPECT and PET rely on the use of radioactive isotopes to create the images. So if any of you have been for a PET scan, you will have had what they will have called a dye. It's a radioactive tracer pumped into you for them to get the contrast in the images. Again, we need to make sure that we're giving people the right amount of dose, and we trace that back to our primary standard. This is where I took the gory picture out. Obviously, things like PET and radiotherapy, we probably all hear quite a lot about, given the ever-increasing numbers of people suffering from cancer. In the UK today, 27 people are currently having all or part of a foot amputated because they have a diabetic foot ulcer. You'll have undoubtedly seen in the press stories of the increasing rates of diabetes, largely lifestyle caused. You very rarely hear about the huge challenge of managing the comorbidities that come along with having diabetes. And foot ulcers, sadly, are a very big part of that. Managing diabetic foot ulcer costs the NHS $5 billion a year. $5 billion a year. And the sad truth is that those 27 people who are having an amputation today, 13 of them will be dead in 2 years' time. So, this is where we come in. A couple of years ago, we were doing some work using thermal imaging. We do quite a lot of work in thermal imaging for lots of different applications that range from looking at waste drums to looking at satellites in space. And one of our scientists made the link that the way in which he was modeling the thermal heat signatures of satellites could be applied to a problem in diabetic foot management. It is well known and has been established through clinical trial that somebody who is developing a foot ulcer will get a heat signature develop on their foot about 10 days before that ulcer develops. And you can take action to prevent that foot ulcer developing if you can pick up that heat signal. So there is a fairly well-defined clinical pathway of high-risk patients coming in to see podiatrists and having their feet checked. And one of the ways in which the podiatrists can do that is they can take temperature measurements across the foot with a thermometer. They need to take at least 13 points across each foot, and they need to get the equivalent point on the right foot and the left foot. That is not straightforward to do. And so, in fact, temperature measurement of feet, because it takes 13 minutes to do that for every patient, has not been well established in the UK. This is a potential solution. We ran a collaborative study with a number of players who have got expertise, particularly in the management of diabetic foot ulcer. And we've basically taken a device that is a fairly off-the-shelf thermal imaging camera, it has to be said, but it had to be calibrated very exactly because the difference in temperature is less than 2 degrees. And most thermal imaging cameras are not precise enough in terms of the temperature measurement that they will pick up and distinguish. Not only that, but we had to deal with this left-right foot comparison. We've done that through machine learning. So we've had, and part of the reason for collaborating with these folks in various hospitals is to have lots and lots of diabetic patients come through with 2 feet that we can image. And we can get that image in 10 seconds. In fact, I can take that image in 10 seconds. So this isn't just about technology. We come back to how do you fundamentally rethink managing diabetic people and their feet in a healthcare system where actually, potentially, they could be doing this in boots, not having to be in a hospital. So this is some technology that we're actually in the process of further developing and taking out to market, hopefully with a third-party investor. But it's also an example of where we've taken technology that was from a space program and applied it to health. Here's another one. If, like me, you're of a certain age, you're starting to get invitations for a really uncomfortable procedure called mammography. Rates of breast cancer in the UK are relatively high, not grossly higher than anywhere else in the world. But what we do see is that increasing rates of breast cancer in younger women, and younger women tend to have denser breast tissue. It's much, much harder to pick up tumours in dense breast tissue. It's also even more uncomfortable than the current squashing that goes on in an X-ray mammography. The problem with mammography also is that we stop screening women at 70. The reason is because by then they've had enough X-rays to the breast tissue that they're at risk of developing a radiation-induced tumour as opposed to any other kind of breast tumour. Unfortunately, our current mammography program results in about 33% of our current biopsies are unnecessary, but we still have 11,000 breast cancer deaths every year in the UK. So we do a lot of work again on ultrasound. We use this in multiple ways. We calibrate hydrophones that are used in ultrasound machines. We apply ultrasound to precision mapping of devices underwater. And so our scientific team have taken exactly that precision mapping underwater and said, well, why can't we do that to a human breast? And you can. And in fact, these pictures here are comparing an X-ray CT with what is actually quantitative ultrasound. So what they're doing is that it's a much more comfortable procedure if we come back to user experience, potentially for the patient, in terms of lying down. the breast is held in a bath of warm water. So it's also in the conformationally normal state as opposed to squashed. That makes it much easier to see things, particularly if it's a younger woman with dense tissue. And we're whizzing our transducers around and building up a 3D image. And that's the work that we've got to. So again, technology that we've used and applied for many years in a different setting, but applying it to the problems that we're seeing in healthcare. And then, another big issue in life sciences is that, unfortunately, the reason it costs so much to bring a new drug. Does anybody in this room, by the way, happen to know how much it costs to bring a new drug to market now? Or how long? Last estimate I saw was 1.2 billion, 12 years. And that's with improvements in technology. And the reason for that is most of the time, drugs fail. They fail in clinical trial. And one of the reasons they fail in clinical trial is because we don't truly understand the biological mechanism that underlies the disease and how a potential drug might influence that. And also how a potential drug might actually not go to the part of the body we want it to. Cardiac heart failure is the result of 45% of drug trials fail because of a secondary side effect to cardiac failure. So this is, one approach. This is a new technology being developed in partnership with a number of players called light sheet microscopy. And what we've got here is a model of intestines. Organoids are kind of little, very, very tiny under the microscope, but fully featured organoids that you can run tests in. So this is working with a number of smaller companies, and Celeste is a startup that develops these organoids to look at how you can image this and start to understand how drugs might interface in a more real-world system. So as I said, very much like other industries, it's all about the data. And one of the reasons it's all about the data in life sciences and healthcare is we're pretty complex systems. And you need a lot of data to get statistically significant factors, particularly where we've got people with 5 comorbidities and we're trying to work out what's going on. The amazing thing is, though, that much as we may malign the NHS sometimes, it has the most integrated data set in the world. It's got 70 plus years of medical records. Okay, not all of them are digitized, but the longitudinal value of that data is enormous in terms of our ability to look at multiple complex diseases and use large data sets. It's also we're saying that healthcare is a regulated industry. You've got to provide the evidence that not only are you being effective, but you are being safe in terms of your intervention. So just to give you a few examples of how, again, NPL is picking up on this problem around data and the quality of the data that we can use. There's quite a big problem with primary care, is that sometimes doctors don't completely fill in the records. They're busy people. They're trying to see people in 7 minutes and deal with 85 years old and 5 comorbidities. It's not to be surprised. So one of the projects that we've been running recently is working with primary healthcare deliverers to look at the medical data that they do have and identify ways in which we can automatically fill in the gaps. And that's based, again, on taking lots and lots of data sets, running good, smart algorithms that we truly understand, filling in the gaps for them. Not a picture of a heart, please note, not a picture of a heart. What we have here actually is a kind of artificial heart that we've built. This is to look at how fluid can be pumped in and across heart tissue. It's really important that the rate and amount of fluid, if you're going to pump somebody's heart with it, you get it right. And at the moment, the only way to do that accurately is pretty invasive. It's to take samples as you go. Pretty uncomfortable for the patient. You could use imaging technology, but the problem is it's not quantitative, it's not robust, it's not well understood how the physical measurements of the amount of fluid can be related to the images that you can see. So we've got a project ongoing at the moment to make exactly that link between what the patient is experiencing and the images that are being collected so that we can standardize that data. Once we can standardize that data, we can apply machine learning, we can start to think about how we intervene. We've got the potential to make this a much better system. So that was a really, really brief canter through some technology examples, very much just to whet your appetite. I hope I've given you a flavour of the ways in which technology can play into this, and the role that we play in terms of assurance, supporting innovation, managing data. I think the huge opportunity here is the way in which new technology can give us better data. Because if we have better data, we stand a chance of making better healthcare decisions. And I think that's something that actually we all as individuals want. Thank you all very much.